Hi, Megan, welcome. We're just waiting for a few more folks to get logged in and then we'll get started. Megan, could I ask you to unmute for a moment? Did you have any issues logging in by any chance? Oh, that's fine. If you could write in the chat, did you have any issues logging in by any chance? Oh, no problem. I was just asking if you were able to log in okay, or if you had any difficulty. Okay, thank you. We're just waiting for a few more folks to come and then we'll get started. Renee, any updates?
I think so, because we were supposed to record and post it anyway for those who couldn't attend for a couple weeks, but I'm trying to get in contact with Ms. Westbrook right now to ask what the holdup is.
All right. Well, give you one more minute, and when we get to 2:10, we will go ahead and start, and then we could go ahead and record it. And then we can post it for folks that couldn't make it for them to go ahead and complete the CNE. Minute. Looks like we have another participant in the waiting room, so that's good. All right, so hopefully folks are able to start getting in. All right, well, why don't we go ahead and get started, and Patricia, you can start the recording and we'll get going. Right. Welcome to Maternal Mental Health. It's not just postpartum, it's not just depression. Next slide, please. Right. My name is Jennifer Settlemyer. I am the Director of Professional Education here at the National Office of the March of Dimes, and I'm thrilled to introduce our speakers today. The first speaker that we have is Renee Antoine, and she's the Director of Maternal and Infant Health at the March of Dimes, Louisiana market, and she is your local champion leading the fight for the health of all moms and babies in your state. And our other speaker is Adrian Griffin, a longtime friend of mine and a wonderful advocate in the maternal infant health field. Adrienne is the Executive Director of the Maternal Mental Health Leadership Alliance. She's today's featured speaker. She's an advocate and subject matter expert in maternal and mental health. And prior to joining the Maternal Mental Health Leadership Alliance, she founded Postpartum Support Virginia. She served as the Executive Director of that organization for 10 years, establishing a statewide network of support groups. They were peer-led support groups and created educational programs for mental health providers and maternal and infant health care providers. She helped pass legislation requiring information about postpartum depression and anxiety, requiring that it be provided to new mothers. And she's a fabulous speaker, and we're thrilled to have her here today. Next slide, please. So I'm going to hand it off to Renee, and she's going to talk to you a little bit about what's going on in Louisiana.
Thank you so much, Jennifer. Thank you for having us today. We're very excited about this training. The mission of March of Dimes is to lead the fight for the health of all moms and babies. And we do this by making sure that all moms and all babies are as healthy and strong as possible. This is a multi-sectorial and multi-partner approach. So we have impact in several different categories. We advocate for policies that support moms and ensure access to care for babies. We empower and engage women during pregnancy through our prenatal pregnancy and postpartum programs. We also have elite researchers that identify interventions to prevent maternal death and infant loss. We also support families who experience premature birth in the neonatal intensive care unit with patient-centered care approaches that have been proven to improve birth outcomes. And with partners like you, we unite our communities in support of moms and babies to ensure that everyone has correct access to health care. Next slide. Our 3 overarching goals is to reduce prematurity, babies who are born too sick, too small, or too soon. To also reduce maternal mortality and morbidity, the unfortunate circumstance when a birthing person loses her life during a complication related to childbirth or during childbirth itself. And last but not least, to address underlying factors, including inequities and access issues. We believe that all healthcare should be timely, easy to navigate, and efficient, and meet the needs of its community. Next slide. In order to have very strong impact across the state of Louisiana, and specifically in Ascension Parish, we must have strong state policy priorities. This includes, as mentioned before, access to quality care, research and surveillance, health equity, and prevention and treatment. Today, we're going to focus on maternal mental health. Next slide. A mother's mental health is directly connected to her physical health and the health of her baby. Many women experience mental health challenges during pregnancy and the postpartum period. Maternal health issues are the most common complication of pregnancy and childbirth, and when left untreated, maternal mental health disorders can have a serious medical, societal, and economic consequence. March of Dimes has identified 5 key elements that are critical to addressing and improving maternal mental health. Access to and insurance coverage for all types of mental health care. Universal screening of all pregnant and postpartum women. Referral to behavioral health providers for treatment. Public health education on the prevalence of maternal mental health issues that focus on normalizing the stress new parents face and stigma reduction strategies. Robust funding to support tracking maternal mental health disorders, as well as data collection on maternal mental health screening initiatives and treatment outcomes. Untreated maternal mental health disorders cost the U.S. an estimated $14 billion each and every year. Evidence suggests that rates of maternal mental health disorders are increasing during the COVID-19 pandemic. Next slide. We are very excited to be working on legislation from the updated protocols for the Louisiana Perinatal mental health screening. Currently, any child that has Medicaid can have their caregiver screened at every single well child or sick visit from birth to 1 year. These perinatal depression screenings would include the Edinburgh Postnatal Depression Scale, as well as the Patient Health Questionnaire, PHQ-2 and PHQ-9. This legislation is monumental for the health of all moms and babies because we now know that navigation through the maternal mental health screening process will be easier, more efficient, and more timely for all moms and babies. Thank you.
I'm going to bring it back for some quick housekeeping. Thank you for the wonderful overview of what's going on in Louisiana. The legislation is particularly exciting as that will provide access for a lot more women and screening for a lot more women. So I'm going to go through some disclosures and some information about our accreditation. So today, neither the speaker, Adrienne, nor any member of our planning committee has any financial, professional, or personal relationships that could potentially bias the content of this presentation. No commercial support was received for the development of this presentation. However, the Gonzales Rotary Club provided support to deliver this training free of charge to all of you today. So thank you to the Gonzales Rotary Club. The learning objective is that participants will be knowledgeable about maternal mental health issues, including knowing how to screen for these illnesses and how to connect women with resources for recovery. You will receive 1.5 CNE for attending. At the end, I have the information here, but also at the end of this presentation, there will be a slide that you can go to. There will be a barcode you can scan or a link you can click on. And when you go to that, within 15 days of this presentation, you'll be able to fill out an evaluation and earn that 1.5 CNE. And then by the end of the month, basically by the first of the month, we'll send you a certificate for your participation and evaluation at today's event. We are accredited as a provider of nursing continuing education by the ANCC. And so we're thrilled to be able to bring this presentation to you today. So I'm going to hand it off to the wonderful Adrian Griffin for her talk today. Thank you.
Thanks so much, Jennifer and Renee. It's really great to be with all of you today, and thanks for taking time from your busy lives to be with us as we talk about maternal mental health issues. So I just like to start off with this slide about the happiest time in a woman's life, right? Having a new baby. I mean, just look at these pictures, how glorious they are, the golden glow around all of them. I mean, it's just so perfect. Well, not always. At least not in my life. I mean, we see the dirty diapers, the dirty dishes, the piles of laundry. I love this little guy up here in the left-hand corner screaming. And of course, this would be my 2-year-old having the tantrum on the floor. So, that beautiful time in life is not really always so perfect. In fact, maternal mental health issues are the most common complication of pregnancy and childbirth, affecting 1 in 5 women, and up to 1 in 3 in high-risk populations. As I said, these make them the most common complications of pregnancy and childbirth. And really strikingly, we know that 75% of women who experience maternal mental health symptoms go untreated. So just a little bit about me and what brings me to this work. So I had severe postpartum depression after my second baby. I had no history of anxiety or depression, but looking back, I had an emergency C-section, I had kind of a needy baby, and I had a toddler. And I was exhausted and I was overwhelmed and I could barely get my head above water. I felt like I was drowning all the time. And I knew right away that something was wrong, but it took me about 6 months to get the help that I needed. And during that really dark time in my life, I decided that I needed to do something to help other women so that they would not be impacted the way that I was. So there's this lovely picture of me with my son. He is the child that I had postpartum depression with. And we looked so beautiful and happy. And I was really ready. I actually ran away from home at just about that time. I told my husband, I can't do this. I am out of here. You can have the house, the kids, the car. I'm just going to go somewhere and sleep for like 3 years and then I'll be back. Once I got better, had another child, and I started volunteering with an organization called Postpartum Support International. I started answering calls for moms in Virginia, where I live. And then I started a support group at a local hospital. And then this led me to launch Postpartum Support Virginia, which was its own nonprofit organization affiliated with Postpartum Support International. And as Jen said earlier, we created a statewide network of support groups. We did lots of trainings. We ran coalitions. We did all kinds of stuff. It was really very, very fulfilling. And then in 2019, I had the opportunity to step up to the national level to work at Maternal Mental Health Leadership Alliance, where we really focus on national policy. And, I remember thinking back when my son was a baby, like, how am I going to get through the next 18 years until this child goes off to college? Well, we did. There he is. He's 6'4". He went off to Clemson. He's coming home tomorrow, and we survived. And so, I just offer that up as a little bit of hope that we can get through really whatever tough road we are thrown. Okay, so just a quick poll about who is in the audience. We only have a couple of people. So a nurse, doctor, midwife, anybody want to just sort of maybe just put in the chat? Oh, there we are. Yay, we have our poll. All right, so I guess you can select on one of these. It doesn't look like, oh, there we go. I'm not sure if the poll is working, but so maybe, we're gonna try it again. Okay, so.
Sorry, Adrian, why don't you have them participate with the chat?
Sure. Yep. So why don't you just go ahead, if you can, put in the chat what your line of work is. Are you a nurse, a doctor, a lactation consultant? Just so I kind of have an idea of who we're talking with today. That would be great. And if you don't know how to, just click on the chat down at the bottom. It's in the middle. It says chat, and it will pop up, and there'll be an opportunity to put something in there. So we've got a nurse, we've got an advocate. Anybody else want to add in? All right, well, feel free to chime in. Okay, so let me move on to the next slide. All right, so just another quick question about how much training have you had regarding maternal mental health? And again, we'll just go ahead and put that in the chat, whether you've had some training, no training, a little bit of training. All right, so here's what I'm going to talk about today. A little bit about an overview of perinatal mental health or maternal mental health issues, the impact on the mother, on the child, and on the family, treatment, screening, and then where to learn more. Okay, so maternal mental health issues. We hear lots of different terms thrown around. We used to talk about postpartum depression. But as we've learned a lot, it's not just in the postpartum period. These issues can often start during pregnancy. And it's not just depression, it's also a lot of anxiety. So what we're really looking at is this perinatal timeframe. So roughly the 2-year period from conception to baby's first birthday or the first year following pregnancy. And we're looking at both mood and anxiety disorders. So on the mood side, it's depression and bipolar disorder. And then the anxiety side, general anxiety, maybe obsessive-compulsive disorder, PTSD, they all sort of fall under the general umbrella of anxiety disorders. So what's really striking about all of these issues is that many, many women actually enter pregnancy already developed with symptoms of anxiety or depression. So of women who experience maternal mental health issues, we see that 27% or almost a third enter pregnancy with anxiety or depression. Another third develop symptoms during pregnancy, and then the final third or fourth develop symptoms following childbirth. So this is why we really need to start talking about these issues during pregnancy. So other terms that you might have heard, for a long time, we just used the term postpartum depression. Some people say perinatal anxiety and depression, antenatal, meaning during pregnancy, perinatal mood disorders, perinatal mood and anxiety disorders, or shortened to PMADS, or maternal mental health complications. During this talk, I will be using the term maternal mental health complications. So let's start with the extremes. So first up is the baby blues. So this is very, very common, affecting the majority of women. It's the normal period of transition. It resolves without treatment within 2 to 3 weeks. And if you're a mom, maybe you have experienced this, maybe we're a little emotional sensitivity, some weepiness, a little bit of feeling overwhelmed, but it's not constant kind of ebbs and flows. Like I remember with my first baby, I'm going through the baby blues, and like I remember the mailman dropped off the mail and I just started crying, like, thank you so much. Like, you know, you just sort of up and down, up and down. At the far extreme is a very rare illness called postpartum psychosis. This illness affects 1 to 2 women per 1,000 births, and it's a medical emergency. The onset is often sudden and usually within the first 2 weeks postpartum. And this is, sadly, this is what the news reports as postpartum depression. This is when a mom may be at risk of hurting herself or her child. The signs and symptoms include delusions and hallucinations. She may be this is a real break with reality. And what's kind of scary about this is that mom can kind of waver in and out of that psychotic episode. But it's definitely a medical emergency, and mom needs to be not left alone. And most likely, if she is in danger of hurting herself or her child, the emergency room is really the safest place to be. Okay, so now let's look at sort of the core of the maternal mental health issues. So of course, everybody knows what depression is. Feelings of sadness, of hopelessness, feelings of worthlessness, lack of energy, but also, especially in the postpartum timeframe, there's lots of signs of irritability and anger and rage. I remember feeling so angry at the whole world, but particularly at my husband, that, you know, he got to go off to work and I was stuck at home with this crying baby. So a very highly irritable depression. Symptoms of anxiety, feelings of overwhelm, feeling stressed or panicky. Moms who experience postpartum depression are often very hypervigilant, watching baby all the time, afraid to leave baby alone. Again, the irritability, the anger, and the rage, it sort of crosses over between the depression and anxiety. So it's a very stressful kind of depression or anxiety. I want to talk a little bit about post-traumatic stress disorder, because this often will happen if a woman experiences what she perceives to be a traumatic birth, or if she has a previous history of sexual trauma in her life. And so like with full-blown PTSD, women can experience nightmares and flashbacks. They may have avoidance issues. They may avoid coming to the hospital. They may avoid talking about their birth story. And again, this is if a mom perceives that it's traumatic. So I remember when I first started this work, I was talking to a mom who said that the doctors needed to use the vacuum extractor to help her baby be born. And she heard somebody say, oh my gosh, it's coming off, meaning the extractor was coming off the baby's head. But what she thought was that the baby's head was coming off. And baby was born vaginally, so sort of a medical, success story, but she had this repetitive nightmare of her baby being decapitated. And so I think this avoidance talking about the birth story is really an interesting sign that a woman may be experiencing PTSD. And then the final manifestation that I want to spend some time talking about is obsessive-compulsive disorder. So most of us have heard about OCD, where there's obsessions, and then there's the compulsions that people do to overcome the obsession. So for example, if you're obsessed about germs, the compulsion might be that you wash your hands a lot. Okay, during this time frame, OCD manifests itself most often in intrusive thoughts that the mom may hurt herself or her baby. And these thoughts are very, very scary to her. And she will take lots of steps to not engage in those thoughts. So for example, I remember with my son standing at the top of the stairs one day thinking, what if I just fell down the stairs? Would we be hurt? How long would we lie there? What would my toddler do? And meanwhile, I was gripping the banister so that my knuckles were turning white. And I actually, from that point on, if I was holding my son, I would go down the stairs on my rear end so that I wouldn't fall down the stairs. So again, in the OCD, it's these intrusive thoughts that are very unsettling for the mom. So I'm going to talk a little bit about the difference between OCD and psychosis. In OCD, thoughts are things like dropping the baby, letting go of the stroller into traffic. Often women will have thoughts, visions of using knives to harm their baby or themselves. But these thoughts are very scary to the mom. We call it ego-systonic, meaning that they are inconsistent with what the woman believes to be true. I'm sorry, this should be ego-dystonic, not systonic, ego-dystonic. They cause great deal of alarm and distress for the mom. And the mother has a real fear of acting or thinking about these thoughts. And so her avoidance, her rituals all are about avoidance. So for example, one mom said she had visions of using the knives. Her husband locked up all the knives and put them somewhere where she wouldn't find them. Another mom talked about wanting to drop her baby off the balcony. So she locked that balcony door and put a lock around it so she would never go out there. So they take real avoidance to avoid these thoughts and to not act on them. When women are experiencing postpartum psychosis, these thoughts ring true to them. They are ego-systonic, they make sense and cause no distress or alarm. This is when we're we have a lot of concern. Things like, only I can save my baby by killing him, or the devil is telling me to do things. I was leading a support group once and a woman came in and partway through it, she's like, you're recording me. Stop recording me. She started looking under the chairs, trying to find, the bugs that we were using to record. So this is kind of, an idea this woman is really having a break with reality. Women who experience postpartum psychosis have no guilt about having these thoughts, and they have a strong desire to act on them. You'll see very bizarre behavior, like I explained, extreme agitation, and inability to sleep. This is a real telltale sign of postpartum psychosis. And as I said earlier, it's extremely rare, but it is a medical emergency. So I'll stop there and just see if anybody has any questions about the difference between OCD or psychosis. It's really important to understand the difference, because when a mom says, I'm having these thoughts about hurting my baby and it's very scary to me, that's a good thing. If she says, I'm having thoughts about hurting myself or my baby and I want to act on them, that is not good. That is not good at all. So women are often very frightened to talk about this because they fear that they'll be judged or that Child Protective Services will be involved. That's why it's really, really important that we as maternal child healthcare providers and the mental health providers who work with these women clearly understand the difference between the ego-dystonic on OCD and the ego-systonic of postpartum psychosis. Okay, so signs and symptoms of maternal mental health issues. So lots of times there's conflict with the partner. One of the therapists that I work with a lot, she says that it's like a very brittle time frame. The mom may avoid having any kind of touch or any sex or anything with her partner. Same kinds of issues around baby. Oftentimes there'll be feeding issues. Maybe mom wants to breastfeed but can't, or wants, would prefer to give a bottle but feels guilty. All kinds of feeding issues can be manifested during this time frame. Also hypervigilance around the baby, or the other extreme, which is ignoring the baby. I talked to some pediatricians who say they can tell moms who feel postpartum depression because they'll put the baby down on the changing state on the table for the doctor to evaluate them, and then just sort of back away. They're sort of afraid of their baby almost. Fear of being alone with the baby. Mom saying things like it was a mistake to have the baby. We see this a lot of sleep issues, difficulty falling asleep or staying asleep. These are signs of anxiety. Sleeping too much. Those are signs of depression. Women, again, as I said, who may have experienced a traumatic birth may have nightmares. So sleep issues are really a big cause during this time frame. We talked about thoughts, about scary and intrusive thoughts. Moms will have racing thoughts, maybe poor concentration. I remember I just couldn't get it together. That's just how I used to be really smart and really with it. And I felt like this baby just drained my brain. There can be physical symptoms. If a mom is experiencing anxiety in particular, she may have increased sensitivity to stimuli. I remember my husband would come home from work and he would turn on the television or turn on the radio and turn on the ceiling fan and turn on the lights. And I would walk around behind him, turning all of those things off. Like my brain couldn't process anything. We see women who have panic attacks, women who say that they have headaches or stomach aches. These are all physical manifestations of anxiety or depression. And then there may be changes in the personality. Again, the extremes. A mom may be acting out, maybe doing things that are very outside of her personality, or she may be withdrawing. There always seem to be these near frantic efforts on part of the mom to gain control of the situation. And we hear moms saying things like, my baby, my partner, my family would be better off without me. When we hear that, that is a really important sign that that mom needs help right away. So these illnesses are what we call biopsychosocial illnesses. So they're multifactorial. There's many things that add up to a woman's experience with a maternal mental health issue. So let's start with the biological factors. We know that women who are at increased risk for maternal mental health issues are those who have a personal mental health history or a mental health history in their family. Maybe they have a reproductive history. Maybe they had, PMS symptoms when they were a teenager. Maybe they had fertility issues. Maybe they had miscarriage. So, can kind of trace back and see that maybe something was kind of off already in their hormonal milieu. And then general health issues. Does mom have a thyroid issue? Is she overweight? Are there other things that contribute to maybe us feeling depressed or anxious in the perinatal time frame? So then there's psychological factors. And I think of those as sort of like the inherent personality and behavior of a woman. Women who tend to be a little more type A and a little bit more controlling tend to be a little bit more anxious. There may be relationship and role issues, right? Welcoming a baby into the household really throws everything into chaos. And so sometimes those relationships need to be renegotiated a little bit. And we see lots of times women have unrealistic expectations. As I showed you earlier, all of those beautiful pictures about motherhood, right? We think it's just going to be this beautiful time frame that I'm going to be happy. I'm going to love being pregnant. I'm going to love being a new mom. I'm going to love breastfeeding. I'm going to love everything about this. And when those expectations are not met, women sometimes feel like they are failing, and that can contribute to these feelings of anxiety and depression. And then there's social factors, which I kind of think of as things that are outside of sort of the woman's body or her brain. We think about things like trauma, right? Did she, as I said, have a traumatic birth? Was she a victim of sexual trauma at some point in her life? All kinds of social changes that are happening during this time frame. The childbearing years often line up directly with the working years. And so change of job, moves, buying a new home, of course, things like the pandemic, things that are well beyond our control. So there's these three buckets of things that really kind of overlap and can really cause to exacerbate feelings of anxiety or depression. Hormones play a huge and important role. I want to show just a couple of slides. So there's this first one during pregnancy, and it shows the big red line is HCG. That's the hormone that is first tested when a woman does a pregnancy test to see if she's pregnant. And you can see that tapers back off pretty quickly. Meanwhile, estrogen and progesterone start ramping way up. And so by the time the baby is born, they are like at 100 or 1,000 times what they were before pregnancy. Okay, then we look at the postpartum time frame, and it gets even more complicated. So progesterone and estrogen start to cycle down. Meanwhile, oxytocin and prolactin kick in, and they sort of are operating at opposite each other. Prolactin stimulates milk production, oxytocin stimulates milk ejection. And this can be, some women find this to be a positive feedback. They can increase each other's effects. Some find them to have a negative feedback. Some women find, for example, that when they're breastfeeding, that they feel this sort of temporary but overwhelming feeling of sadness. And it's passing, but it is kind of triggered by this huge hormonal fluctuation that's going on. And for women who are sensitive to these hormonal changes, this can really have a big toll. So let's just have a little bit of a discussion here. We can do this through the chat. If you are a mom, now that I've explained some of these things, did you experience anxiety, depression, or other mental health issue during pregnancy or postpartum? If you want to put that in the chat or raise your hand, Would love to talk about that. And if so, like, what do you think contributed to your experience? Like I said, you know, I look back and I realized I had that very scary emergency C-section. You know, they were running down the hall so fast, my husband couldn't keep up. You know, then I had this needier baby. My first baby was really easy. She slept all the time. And my second baby was, I guess, a more normal baby, but wanted to be held all the time. You know, and I had this toddler and I was just really exhausted and overwhelmed. And I see maybe, I'll admit, I might have had a little anxiety earlier in my life. So like, I see how those things all kind of contributed to my experience. So anybody else want to chime in there or talk about your experience? All right, well, if you think of anything, you can always add it to the chat. I do find, though, that after I've explained all of these different manifestations of maternal mental health issues, that if I'm in a live audience, I'll see a lot of people nodding their head like, oh, that's what was going on. I didn't realize it at the time, but maybe I was having a little postpartum depression or anxiety. So in your experience, because I know that all of you work with lots of moms, which mothers are at increased risk of experiencing anxiety, depression, or other mental health issues? Have you sort of noticed a trend? Like where I live, I ran a support group for many, many years. And, you know, we talked as much about breastfeeding challenges as we did about postpartum issues. So I really started to see this link between breastfeeding issues and anxiety. So I'm just wondering if any of you have noticed any kind of trend. Do you see, you know, mothers who maybe are older or younger or educated, or type A moms who are perfectionists? Oh, yes, 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 yes. They want everything to be perfect. Yep. Yep. And they think they have to look perfect. The baby has to look perfect. The house has to look perfect. Yep. Anybody else notice anything? I guess I was kind of one of those type A moms. And so like, I remember sitting in the chair to feed my son, and I'd be like, oh my gosh, look at this house. Look at it. Such a mess. There's the dishes, there's the laundry. And it was stressful just sitting there feeding him. So I actually just turned my chair around and looked out the window, and I was like, oh, this is so much more calming. So, I mean, there are little tricks and techniques that I've learned over time that I like to share with moms. All right, well, if anybody else thinks as we go along of, you know, sort of a common theme that you've seen, moms who have multiple children have many responsibilities. Absolutely, absolutely, especially if they have those children. Oh, and Renee, did you mean multiple births, like twins, triplets?
I meant both, those who have multiples as well as those who already have existing children in the household.
Absolutely. You want to talk about that a little bit?
Sure. So we know that there's always an increased risk of different perinatal mood disorders when you've experienced birthing multiples. Although somewhat rare, multiples are actually becoming more and more common because of you know, assisted reproductive technology and things like that, especially because the average age of mothers birthing is actually increasing in the United States due to educational attainment and delaying, you know, conception and things like that. So that's going to be something that you see a lot more common in the nation as we go forth.
Yep, yep. And you're right, you know, if there's lots of children in the home, especially if those children are spaced very close together, you know, it can be extremely overwhelming. Yeah. And especially, you know, if mom doesn't have a lot of support from her partner or her family, you know, we think about military families, for instance, you know, they're typically away from their home of origin. They might not have a lot of social support. Yeah. So there are certain groups of women who are a little bit higher risk. And in fact, let's talk about that. So women at increased risk, we know women who have a history of anxiety or depression, those who don't have a lot of support, especially from their partner, who have experienced trauma, or who face economic or racial inequities. And then there's some certain subgroups of women that we know that are even higher risk. So immigrant women, for example, they often are away from their family. Sometimes they leave their children back home in their home country. And so they're already missing their children. There's issues of language and culture, and, you know, all this deportation rhetoric can also really compound their feelings of anxiety in particular. We know that military moms are at increased risk. As I said, they're often away from their family. Their partner may be deployed. They may be giving birth all by themselves. There's frequent moves. They have the stress of deployments and war, whether they're the military member or their partner is. So we know that those military families need a little bit of extra assistance. And we know that parents who have a baby in the NICU are at high risk for anxiety. They're worried about the health of the baby. It's a very high stress environment. Typically, it's been kind of a traumatic birth and the baby is whisked away. Then there's this stress about, especially if there's other children at home, where should I be? Should I be in the NICU with my baby? Should I be home with my other children? If the baby has to be sent to a different hospital, then there's this concern about distance and, just lots of stuff wrapped around with having a baby in the NICU. Postpartum support is very important. Oh yeah, we're going to get right to that. Yep, thanks, Renee. It's like you're feeding me my upcoming slides. So we know that women of color, in particular, are at risk for maternal mortality issues. If you've read the newspaper in the last 2 or 3 years, you have to have seen stories about that Black women are dying at 3 to 4 times the rate of white men. They have higher rates of C-section. They're twice as likely to be readmitted to the hospital. They have disproportionate rates of all kinds of health disorders. And they are twice as likely to have postpartum depression, but much less likely to get treatment. And why is that? Well, social determinants of health, they have lack of access to healthcare. The hospitals where they live are lower quality. There's bias in the medical system. Women report over and over again feeling devalued, disrespected, and discriminated. And Black women live with constant stress in their life. There's this effect called weathering, which when I first heard this, I was like, oh my gosh, it makes so much sense. If you're living in high stress, you think about your body is always revved up, right? And women, we know Black women often say that they have to do twice as much to prove they're half as good, right? And so this chronic stress, it's almost like revving your car engine all the time, and it really wears down on the body. And so that Black women actually age faster physically than white women. And then also epigenetics, so that this stress and this weathering can be passed down from generation to generation. So all kinds of issues for women of color. So it's sort of the perfect storm. There's these hormonal changes, there's sleep deprivation, which can be really, really significant for some people. It's the single biggest identity transition in most women's lives. We talked about the unrealistic expectations. If there's any difficulties during pregnancy or birth, any predisposition for depression or anxiety, and then lack of access to quality healthcare, whether it's healthcare or mental health care. All right, so let's talk a little bit about impact. So why should we care about these issues? Well, this chart is from a study that was done in 1987, and I still use this. I'll also tell you that's the year I graduated from college, so this is about 35 years old. This study has never been replicated because it showed so clearly admissions to psychiatric hospitals in the 2 years pre and post pregnancy. And it's just striking. You can't help but miss that spike right around childbirth. And more, we're learning that suicide and overdose are 2 of the leading causes of death for women in the first year postpartum. And this is really, really striking. We've seen more and more reports from maternal mortality review committees in different states and jurisdictions that are showing that women are using the most lethal means of suicide during the postpartum timeframe. They will hang themselves, they'll use guns, or they'll jump. We also have seen statistics that most women who die by suicide do not attend their postpartum obstetric visit, but they visit the ER within a month of taking their lives. So we know that they are reaching out for help. In fact, there's a children's hospital here in Washington, D.C., recognized that women were showing up in the emergency department at the children's hospital, bringing their baby in, saying, I'm worried about my baby, and making these repeat visits. And they realized that these women were actually very anxious and depressed. And so they started screening new parents in the emergency department at Children's National Hospital. And they really picked up on a significant number of women who were experiencing postpartum depression or anxiety. So what are the risks if we don't treat these illnesses? Well, there's risks during pregnancy and there's risks in the postpartum timeframe. So during pregnancy, women who are experiencing maternal mental health issues are more likely to have poor health habits, maybe not get the prenatal care that they need, and they're more likely to abuse substances. And this can increase the risk of all kinds of poor birth outcomes: preterm labor, small head size, low birth weight, prolonged labor, NICU admissions, none of those things that we like to see when baby is born. In the postpartum timeframe, women who are experiencing maternal mental health issues are more likely to have decreased response to their baby's cues, leading to fewer positive interactions with the baby. As I already mentioned, there's also a lot of times breastfeeding issues. And all of this can increase the risk of poor health outcomes for the baby. So impaired attachment, children who have a parent who are anxious or depressed are at higher risk for behavioral, cognitive, or emotional issues. They themselves are more likely to need psychiatric care and have suicidal behavior. So it's really, really important that we make sure that the mom is doing well. If the mom is doing well, the more likely the child is going to do well. Other risks of untreated maternal mental health issues, so there's the impact on the father or the partner. We know that maternal depression is the #1 predictor of paternal depression. And we know that 1 in 10 dads will experience postpartum depression or anxiety. And we know that men express their anxiety and depression in different ways. They express it much more with anger, with frustration, and with stern discipline for the other children in the household. In addition, depressed parents are more likely to overuse the healthcare system and the ER and the emergency department, as I already mentioned, and they're less likely to adhere to guidelines for safe sleep and car seat usage. There's also untold costs of untreated maternal mental health issues. So there's the impact on the relationship with the partner or the spouse. I remember during this time frame, I said I was so angry at my husband. I was yelling at him all the time. It really took a toll on our marriage. There's impact on the other children in the household. We see that women sometimes who experience anxiety or depression decide not to have another baby, that it's just not worth it, that it was too debilitating. And there's also real societal costs. Renee mentioned this earlier. The cost is $32,000 per mother-child dyad, or $14.2 billion with a B, billion dollars each year in the United States in addressing those poor birth and health outcomes that we discussed, and also in the lost wages and productivity of the mother. And so we use this information a lot when we're working to advocate for new funding, for new programs, for new laws, because this is a significant cost to our economy. As I mentioned before, maternal mental health issues and breastfeeding are often linked. It's sort of the chicken and the egg. We're never quite sure which one comes first, but we know that depressed mothers are less likely to breastfeed and more likely to stop breastfeeding if they have started. We also see that women with anxiety can really make breastfeeding a fixation. We hear over and over again, I ran support groups for about 10 years. If women didn't give birth the way that they wanted to, if they had to have a C-section, if they had to be induced, they'll say, I failed at giving birth, so I'm going to make it up for it. I'm going to breastfeed this child till he goes off to high school. There's this concern because they can't measure the amount of breast milk. Is my baby getting enough to eat? I remember sort of like really clinging to breastfeeding as really the only thing that I was doing right. I felt like I was messing everything else up, but this was the one thing that I was doing right by my baby. Sometimes we see mental health issues rise up when a mom stops breastfeeding, when she weans, because it's another change. And so we sort of have come up with this expression that breast is best. We hear that over and over again, except when it's not. For some moms, for some babies, for some situations, it really is not the right setup. And so we have to give moms the freedom and the permission to make their own decisions about breastfeeding. There's such pressure from certain quarters, exclusive breastfeeding till the baby is 6 months old. Well, that might not be possible. That might not work for a mom or baby. Okay, so what's the good news? I've been going on and on about all the negatives. So the good news is that maternal mental health issues are often temporary and treatable. and mothers, babies, and families can all recover. So let's talk about some of those treatment options. So let's just think about this again. In your experience, if you experienced anxiety or depression, or you've seen somebody who has, what would have helped you recover? So like for me, the thing that would have helped the most was sleep. I'm a very sleep dependent person. My son would not take a bottle, so I was up every 2 or 3 hours. It seemed like for months on end, and I think I was slowly going insane. So if I could have gotten more sleep, I think that would have really been helpful. Anybody else want to chime in or take your microphone off and let me know if there's something that you think that would have been helpful? So we've come up with a thing that we call the steps to wellness, to help women take one step at a time to recover from their experience with anxiety or depression. So we start with the low cost, low barrier items and work our way up the staircase to the high cost items that have a higher barrier to access. So let's talk about self-care. We talk about sleep, nutrition, exercise, and time off. Then there's social support from friends, family, and we'll get into a little bit more about each one of those. Therapy and counseling and medication if needed. So let's take a little bit deeper dive into each one of these things. So self-care, we need to mother the mother. Women need to recover from the physical and emotional aspects of being pregnant and giving birth. And yet in our country, we don't do that. We just expect moms to bounce right back. They're out of the hospital within 24 or 48 hours, maybe 72 if they've had a C-section. And we just think that women can just bounce back. So let's talk about some things that women can do to help take care of themselves. So as I mentioned, sleep, very, very important. What we always encourage is for a new mom to try to get 4 to 5 hours of uninterrupted sleep. And I know when I say that, you are either laughing or crying because as a new mom, you're right, sure, 4 to 5 hours. So how do you do this? Well, the way that we figured it out in our household was that we split the night into 2 shifts. And my husband would stay up with the baby during the early part of the night, and I would go to sleep at like 8 o'clock at night. And then I would wake up at like, 12 or 1 in the morning, mostly because I was breastfeeding, and so my breasts were full, and so I got up and would feed the baby then. And then he would get his 4 to 5 hours of uninterrupted sleep. It is not ideal, it is not romantic, but it is about survival. And if I didn't get that 4 to 5 hours, I was not a good parent. I really couldn't care for my children the way that I wanted to. So sleep is really one of the most important things. The next thing we talk about is making sure that mom is getting enough nutrition, especially if she's breastfeeding. She really needs to eat every time that baby eats. Again, if she's breastfeeding, she needs additional calories. She needs high protein, dense snacks. So one of the things that we talk about is, setting a little feeding station. Right? So if mom typically sits down to feed baby in the same place, why not set a feeding station for mom as well? Because I remember I would get the baby, he'd be screaming, I'd sit down, I'm like, oh, sweat to get him on the breast. And then I'm like, okay, now I'm here for half an hour. I don't have my water bottle. I don't have a snack. So then, we set up a little feeding station. And this is something that a family member can do, right? Pack a cooler of things like yogurt or nuts or granola bars, maybe even a sandwich, a bottle of water, and leave it for mom so that she can feed herself and fill up her pitcher every time that she's feeding the baby. The next thing is exercise. And I am not talking about running the Marine Corps Marathon. I'm talking about a little light exercise, getting outdoors a little bit every day. One of my friends who had severe anxiety, she said her first little bit of exercise was going out the front door onto the steps. And the next day she went down the steps. And the next day she walked to the mailbox. And so little by little, she started getting outside, getting a little bit of exercise, getting away from, she had twins, feeling like she was starting to get a little independent. But just, a walk around the block, especially when the weather is great, the sunshine, the time away from baby, the change of atmosphere, all of that can really make a difference. And then finally, time off. There is no job that is as challenging as being a new mom. You are on call 24/7. You are keeping another person alive. And everybody needs a little break from that. Help mom figure out what that break might be. Maybe it's that walk around the block. For me, once we had 3 kids, I said to my husband, okay, you cannot leave for work until I have a shower, because once you leave, like, I am on call until you get home. And so, figure out whatever that time off is from your job that will help make you feel better. And a combination of these things, I know all of them sound very insignificant, but together they can really make a difference. And best of all, none of these things cost anything. So we always start with self-care. Okay, next up is social support, and Renee already alluded to this. So there's several different ways of different kinds of social support. So first is this emotional social support, letting the mom know that she is valued, creating some kind of warmth, nurturing, and caring, showing her some encouragement, letting her know that she's accepted and valued for the way that she is. The second kind is informational. So this can be guidance and suggestions. So this is sort of like from the wise elders, the mothers, the aunties. They can provide guidance and information and resources. This is what we did as a volunteer for Postpartum Support International. We provide information and resources about where women could go to get help. And we could speak from experience. We could say, look, I've been there. I know how hard this is. You're going to get through this. I got through it. You're going to get through this too. There's also a sense of companionship. You are not alone. Most women who experience postpartum depression or anxiety feel like they are the only woman in the whole world who has ever felt like this, that they are the worst mother in the world. And once they realize that they are not alone, that other women have gone through this, you can see like this complete change in their acceptance of themselves. And then finally, and this is what Renee started hinting at, is that social support can be tangible. It can be real stuff. You can make meals for a friend or a sister, watch the older children, run some errands, fold the laundry, hold the baby so the mom can take a nap. I mean, there are all kinds of things that others can do to help. And again, all of these things are free. And in other cultures, women, once they have a baby, in many, many cultures, the aunts, the moms, the sisters, they all gather around and they help take care of the mom so the mom can take care of the baby. Some cultures have the 40 days of quarantine or lying in, and the mom's sole job is to rest and recover from pregnancy and childbirth. And if we had that here, I just think, we would not see nearly the rates of postpartum depression and anxiety that we do see. All kinds of sources of social support can be friends and family, support groups. Home visitors are a great support. Doulas, again, getting connected with Postpartum Support International, but helping mom think through some of these things, because mom is so overwhelmed. If somebody says, what can I do for you? She's like, I don't know. If you say to her, how about if I bring you a meal? Okay, that sounds good. How about if I come over at 2 o'clock and I'll hold the baby so you can go for a walk? Okay, that sounds good. Be very, very specific. And we always say to new moms, you are not alone. Lots of women go through this, and these are not your fault, and that you are going to get better with help. And this is sort of Postpartum Support International's theme, and what we say over and over, you're not alone, you are not to blame, and with help you will be well. Okay, so then going up the next step on the path to wellness is talk therapy. And again, people think, oh, therapy, oh my God, it's going to be for the rest of my life. I got to lie there and do all the stuff, think about my childhood. No. Therapy during this time frame is very short term, it's very pragmatic, and is very focused on symptom relief. So there's 3 specific types of therapy that are most effective during this time frame. So the first is cognitive behavioral therapy. There's been a lot of research. It's the largest evidence base for depression. It's typically 8 to 12 sessions, and it really focuses on cognitive restructuring. So we have these thoughts that kind of run in like little grooves in our brain. And so, for example, if mom is not responding well to baby, or baby's not responding well to mom, then she starts saying, I'm a bad mom, I'm a bad mom. We need to change that mentality. We do some of this in our support group. So for example, I can't tell you how many moms would say, oh my gosh, at the end of the day, I got nothing done, right? I didn't fold the laundry. I didn't write the thank you notes. I didn't, make dinner. And like, wait, time out. What did you do today? How many times did you feed baby? How many times did you burp baby? How many times did you change baby? How many times did you change your own clothes because the baby spit up on you? And like, to take stock at the end of the day of what you did do instead of what you did not do. And again, that really can help change the perspective. Same kind of thing with that, hey, I would sit there looking at the messy house, and if I just turned around and looked outside, things were better. So there's lots of very small things that cognitive behavioral therapy can do to help moms kind of restructure and focus on positive things. The second type of therapy that's been very successful in treating maternal mental health issues is interpersonal therapy. So good evidence in both pregnancy and in the postpartum time frame. Again, short duration, 12 to 16 sessions. So maybe once or twice a week, you go for a few months. And this is really focusing on the relationship and relationship problems. So whether it's relationship with the partner or maybe relationship with your own mother, there's lots of stuff that sometimes passes down from mother to daughter. And that kind of surfaces during this time frame. So interpersonal therapy, also very well proven during the postpartum time frame. And then the third is developing a sense of mindfulness, right? Being aware and being present in the body. And the goal in this is to change how somebody relates to their thoughts, to their feelings, to their sensations. So again, recognizing, okay, when baby starts to cry, I start to feel agitated. Okay, if I take some deep breaths, if I relax, if I pick up baby and hug him, if I walk outside, like there's different ways to change how I'm feeling about being present in my own body. We get into yoga, deep breathing. Again, some of this stuff may sound a little hokey, but it's really, really powerful when a mom is feeling completely overwhelmed. And again, I'll point to Postpartum Support International. They have a provider directory of over 2,000 mental health providers across the country who have expertise in treating women experiencing maternal mental health complications. And then the fourth and final piece is medication. And so fortunately, there are antidepressant and anti-anxiety medications that are safe to take during pregnancy and while breastfeeding. The goals are to limit the risk of the maternal illness, right? And to minimize risk of relapse. So if somebody has a history of mental health issues and they come into pregnancy on a medication, the idea is to maintain the mom's mental health and minimize the exposure to the baby. So minimizing that risk of relapse by staying on the same medication and minimizing exposure to the baby by using the lowest dose possible that keeps mom feeling well. So there are definitely risks of medicating, but there are also risks of not medicating. It's really a risk analysis. There are lots of medications that women take when they come into pregnancy, and a doctor would never say, oh, you have high blood pressure, you need to go off your medication. Oh, you have a thyroid condition, you need to go off your medication. But for some reason, mental health is optional. And if women come into pregnancy on maybe an antidepressant or anti-anxiety medication, many times their provider will tell them, you know what, it would be better off if you went off your medication. But there are real risks of not medicating because then the baby is impacted by the mother's mental illness. What do I mean by that? Just because, so let me talk about that risk analysis for a second, and then we'll go to the key takeaways. So for example, if a woman is very anxious during pregnancy, those cortisol and those stress hormones can actually cross the placenta and impact the baby. We talked about earlier on, if mom is anxious or depressed during pregnancy, she may self-medicate with alcohol, tobacco, so things that are other substances that actually could harm the baby. And in the postpartum time frame, if a mom is not taking medicine and she might need it, there's real risks, as we pointed out earlier, the risk of maternal depression developing. There's risks to the other children in the household. We talked about, parents not following guidelines for safe sleep or car seat usage. So we want to make sure that mom and dad are both, very level mentally. So key takeaways are: don't stop medications just because a woman is pregnant. Now, there should be a conversation with the obstetrician and maybe with a psychiatrist or whoever's providing that medication. There's no need to make a knee-jerk reaction and say you must go off your medications. And the answer is different for each woman in each situation and each pregnancy. But the bottom line is there are safe and effective medications should a woman need to take them while she's pregnant or breastfeeding. Okay, if you're interested in learning more about medication resources, there's a whole bunch of great apps and websites out there. The Massachusetts General Hospital Center for Women's Health puts out great information anytime there's a new study. They kind of take the study apart and explain what's going on there. So these are all great resources if you want to learn more about medication. LactMed, I know a lot of doctors have on their phones. It's an app that they can use, and it looks about information about all kinds of drugs and breastfeeding, not just about antidepressant and anti-anxiety medication. Okay, so the fourth trimester, anybody hear of this term? This is American College of Obstetricians and Gynecologists is really looking at what they're calling the fourth trimester, or the first 3 months of the baby's life, the first 3 months of the mom's life, where the new mom must really recover from the physical and emotional challenges of pregnancy, childbirth, and motherhood. As we talked about, there's these changing hormones, body images, the roles and relationships with the partner, with other children in the household. There's the real physical work of feeding and caring for a newborn. And of course, the pressure to return to work. And Alison Stubbe is one of the doctors at the University of North Carolina who's really working on this. And she came up with this quote a couple of years ago that sort of went viral, that the baby is the candy and the mother is the wrapper. Once the candy is out of the wrapper is cast aside. All anybody wants to know about is the baby. And the mom is like, hey, what about me? Hey, I need some help. So really focusing on the mother in the fourth trimester. So as I mentioned, it's American Congress of Obstetricians and Gynecologists, who they actually stated several years ago that the postpartum period is devoid of informal or formal support. Okay, these are the doctors who care for women during and following pregnancy, and they are acknowledging that there is lack of support. So they came out with a new statement that said the weeks following childbirth are a critical time for a mother and her infant, that postpartum care should be an ongoing process, and that first contact should happen within 2 to 3 weeks after the baby is born, primarily to check on the mother's mental health and see how she's doing. And that then there should be follow-up culminating with a comprehensive postpartum visit at 12 weeks. And so this replaces just that 6-week postpartum visit. This is much more of a continuum of care during those first 3 months postpartum. All right, so a few more resources to learn more about the fourth trimester. There's something called the Fourth Trimester Project that can be found at New Mom Health. There's a book called The Fourth Trimester, Guide to Healing Your Body. All kinds of websites. Harvard Medical School has something about the fourth trimester. The New York Times wrote an article about the fourth trimester. The National Institute for Children's Health Quality talking about the fourth trimester. So this is really sort of a buzzword. And I'm guessing within the March of Dimes community, you've already been talking about this. Again, just a couple of the resources. I've mentioned Postpartum Support International a couple of times. I just want to summarize here why this organization is so valuable. So first, they provide support to new moms. They have a warm line. Moms or families can call or send texts returned by volunteers. They have about 20 online support groups. They have local volunteers in every state and in many countries around the world. Again, that's how I got started. And the way it would work is, we'd get a call from a mom. As a volunteer, and I know many of these volunteers, we do not stop helping that mom until she's connected with help. There's a provider directory that I mentioned, all kinds of information on their website. They also provide a lot of education for providers. So if you're interested in learning more about this topic, this is a great place to go. They have an annual conference. They have online and in-person trainings. They have a 2-day certification program. They also have a psychiatry access program. So Frontline providers, obstetricians, and psychiatrists can call and talk to a highly trained psychiatrist to figure out how to prescribe medication for moms who might need it. So I highly encourage you to check out their website. They've recently redone their website. It's absolutely beautiful, and you can get lots of great information. There's another program called Psychiatry Access Programs. And I know that Louisiana is fortunate enough to have one of these programs. So the goal of these programs is to build the capacity of frontline providers, primarily obstetricians, to treat maternal mental health issues, and then to connect women with local resources. So the idea being that not every woman who experiences postpartum depression or anxiety needs to see a psychiatrist. Oftentimes your obstetrician or your family physician can provide a prescription if you need it. And they can consult with a psychiatrist to find out, okay, what do you think? Here's what's going on, what kind of medication, what dosage. And then this also saves these scarce psychiatric resources because there's not enough psychiatrists to go around to treat the most complex cases. So here's how it works. These trained psychiatrists will go out and train the frontline providers. And then these providers have access to real-time consultation. So again, they can call and say, look, I have a mom in my office. She has a history of anxiety and depression. She's not on any medication right now. She's tried all these things. I really think maybe it's time to put her on some medication. What do you think? What should we start with? And the psychiatrist can kind of talk them through that. They also then connect the mom with resource and referral specialists who can help her find support groups or therapy, or all kinds of things. And again, the psychiatrist then can treat the most complex cases via teleconference or in person. So right now on my map on the right-hand side, you can see the states that have these psychiatry access programs. The first one started in Massachusetts. Several states, the darker purple ones, received federal funding a few years ago to build their programs, and Louisiana was one of those fortunate states. And then the lighter purple are states that have funding these programs through private means or through foundations. So I'm just going to talk a little bit about the Louisiana program. Have any of you heard of this program, the Louisiana Mental Health Perennial Partnership? Maybe raise your hand or say yes in the chat. I'm just curious if anybody's heard about this. So it's run through Tulane. Yay, Renee, awesome. Yeah, oh, new to Jennifer, okay. So yeah, so Louisiana was one of the fortunate states to get federal funding in 2018. And again, the goal is to support perinatal healthcare clinicians to expand their identification of perinatal risks and mental health symptoms, implement first-line management, so right there in the obstetrician or the pediatric or the family physician, and then make effective referrals to community resources. So there's real-time phone consultation, there's on-site consultation, there's web-based resources and referrals and trainings about maternal mental health. And here's the primary point of contact at Tulane if you'd like to learn more about this. Okay, so the last thing that we're going to talk about is screening and education and how important it is that we talk to all pregnant and postpartum people about their mental health. So what do you think? When should providers discuss mental health issues with childbearing women, and who should lead these discussions? So just again, put it in the chat. When do you think we should start having these conversations with women? Before pregnancy, during pregnancy, at the hospital, in the postpartum time frame? What do you think? So ideally, we would start these conversations before pregnancy, but absolutely, we want to start having these conversations during pregnancy, right? All phases. Yep, yep. So, why isn't my before pregnancy? Yep. All childbearing years, there you go. How about from like, from like teenage years on, like women should be screened for their mental health, because of the hormonal changes across our lifespan. Really, lots of young girls experience anxiety and depression during their teen years. Then there's the childbearing years, there's menopause. Yeah, so across the lifespan for sure. Okay, so for me, the gold standard would be that women were screened from conception to baby's first birthday at these specific timeframes. So during pregnancy, each trimester, at and around delivery, so prior to discharge, with any post-hospital follow-up, they call and say, so, how was your stay in the hospital? How was the food? Was your room clean? How about, hey, mom, how are you doing, right? at that obstetric postpartum visit whenever that happens. And then the pediatricians should pick up screening at the Welch baby visits. So a woman will see her healthcare provider an average of 25 times during this 2-year time frame, 25 times, offering ample opportunity to talk about mental health issues. And all of these organizations have recommended screening during this time frame. And yet many, many still don't do it because they don't know what to say. They're afraid that mom will fall apart in their office. There's all kinds of barriers to screening. So we talk about who should screen. So I really feel very strongly that screening should start with the provider, the obstetric provider, whether it's a midwife or an obstetrician or a women's health nurse practitioner. Mom really looks to the provider as the expert. And if the provider takes it seriously, then the mom will take it seriously. Now, anybody can actually do the screening. Anybody in the office can hand the screening tool and score it, but the provider really needs to be the one who sets the tone. And, you know, some offices designate a PMAD specialist on staff. Sometimes it's a lactation consultant or social worker or a nurse who really has a passion about this, so that if a mom really, you know, comes in and she's desperate, the whole office isn't thrown out of whack. They know who in the office is the specialist. So what screening tools should be used? The one that is used most often is called the Edinburgh Postnatal Depression Scale, the EPDS. It is, it's been around since 1987. It's free, it's short, it's easy to score. It's been validated in both pregnancy and postpartum. And most importantly, it assesses for depression, anxiety, and suicidality. Very, very important. It asks for how is the mom thinking, has she thought about taking her life? And it also controls for changes associated with pregnancy and postpartum. So for example, it doesn't ask about, has your sleep changed? Because yes, your sleep has changed. Have you lost or gained weight? Well, yes, because you just had a baby. And so, you know, it's very, very practical for the perinatal and the postpartum timeframe. So what should we say? How do we talk about maternal mental health issues? We should talk about them early and often. So here's some conversation starters. Things like we can say, look, all childbearing women are at increased risk for anxiety or depression. In fact, it's the #1 complication of pregnancy and childbirth. We screen all new moms. The transition to motherhood can be a challenge. Having a baby in the house can be a challenge. You know, there's many changes that are taking place. There's this lack of sleep, all these expectations, all the stuff that we talked about. All of those can be good conversation starters. So I came up with a sort of possible script that I think would have been super helpful if somebody had said to me, if my obstetrician had said, hey, you know what? Your mental health is as important as your physical health. And every time I see you, I'm going to ask you, how are you doing? You know, I'm going to weigh you, we're going to measure the baby, we're going to take your blood pressure, but I'm also going to ask how you're doing. And periodically we'll give you a screening tool. And my job is to ask how you're doing, and your job is to be honest, because if something starts to go wrong, we want to get you identified, you know, we want to get you connected with resources as soon as possible. That would have changed my life. If somebody had said this to me, well, I wouldn't be here saying it to you today because I wouldn't have experienced a horrible experience that I did have. However, there's barriers. From the provider's perspective, they talk about lack of training, lack of reimbursement, and lack of resources. I don't know what to say. I don't know what to do. You know, if I ask about it, it's only going to make it worse. I don't have time. You know, lots and lots of barriers. And we can overcome all of these. And providers who care about this issue overcome all of these barriers. There's also barriers from the mother's perspective. So sometimes women feel shame and stigma. They're definitely afraid of being labeled a bad mom. There's real fear that child protective services will become involved. In fact, when I reached out to help in my HMO and I ended up in the behavioral health organization, and I said, you know, last night I was so angry at my son, I had to give him to my husband and walk away. And the nurse, the intake nurse said, I'm going to call Child Protective Services if you've hurt your child. And I said, hang on, I am here trying to get help so I don't hurt my child. There's logistical barriers to care, such as transportation and childcare. And, you know, lots of times women may not recognize that they're suffering a mental health issue. They may just think that this is what it feels like to be a new mom, to be exhausted and overwhelmed and angry and uptight. So we talked about these things, the shame, the stigma, cultural issues. Moms might not know that anything is wrong. They don't know where to go or what to say. They're afraid, they're ashamed. There's all kinds of stigma around mental health still. And then the physical things, the time off from work, the transportation, the childcare, the insurance, the time. I will say, one silver lining of the COVID pandemic is that we can now perform a lot of these screens and mental health care via telemedicine. So many of these physical barriers have gone by the wayside. All right, so some solutions. 3 quick ones and then we're almost done. Number 1, mental health must be treated as importantly as physical health. We have to have mental health parity insurance. We have to work on the stigma around mental health, and mental health should really be embedded with physical health, right? There's no health without mental health. Number 2, resources must be widely available, whether it's a support group, access to a therapist, an inpatient program, medications, prevention programs. We need to do a much better job of making resources. We know which resources work. We need to get them out there and make them more widely available. And 3, providers must be educated and trained. Knowledge is power. We need to dial this all the way back to medical school and nursing school. Residency programs for obstetricians and pediatricians and family physicians should have a lot of training in this. This is the most common complication of pregnancy and childbirth. And we need more fellowship programs for psychiatrists so that we have more highly trained psychiatric providers. Okay, where can you go to learn more? All of these great organizations offer training. Some are short, some are long. Again, Postpartum Support International is a great place to start. Group to peer support, if you want to learn how to be a support group leader, all kinds of great places to go for training. There's a national curriculum in reproductive psychiatry that's broken into learning modules. The Marseille Society is another organization that has a conference. It's very heavily focused in research. And again, Postpartum Support International, I can't mention it enough times, support to parents, provider education, and an annual conference. And then many resources added by the March of Dimes, which is awesome. We've got different phone numbers, National Alliance on Mental Illness, Suicide Prevention Lifeline, and hopefully we are working really hard on, fingers crossed, getting funding for a dedicated maternal mental health hotline so that moms, if they're up in the middle of the night, feeding their baby for the 13th or 14th time or whatever it feels like, they can text or call or get to talk to somebody right away, a specialist in dealing with maternal mental health. And then some specific resources for Louisiana. And Renee, do you want to talk about any of these?
Sure, just very quickly, these are some additional resources for treatment, for screening, for referral. We have the Bridge Center for Hope, Capital Area Human Services, Ochsner, Our Lady of the Lake Physician Group. Several of these are where you would send someone for screening, treatment, and referral. And this is not an exhaustive list, but these are some of the main ones that we have available. Thank you.
Awesome. And one of the things my organization is working on is we're calling it putting maternal mental health on the map, that we're going to have a map of the United States and you'll click on your state and it will open up a whole list of not only resources, but, is there a maternal mortality review committee in your state? Is there any legislation? Is there a psychiatry access program so that you get a glimpse of all the services in your state? So we're working on that slowly. So there's just a little bit about my organization, the Maternal Mental Health Leadership Alliance. We work on building partnerships, leading change, and addressing inequities all around maternal mental health. And then our social media handles, if you're interested in following us and signing up for our newsletter. And here is my contact. Oh, nope, I got one last little quote. Birth is not only about making babies, it is about making mothers who are strong, confident, and capable, who trust themselves and know their inner strength. And then there you have my contact information. I am so happy to talk with any of you after this. You can call me, you can email me. This is my passion. This is what I do 100% of the time. I'm so glad you all were able to take time to be with us today. And I'll turn it back over to Jennifer to close it out.
Right. Next slide, please, Adrienne. All right. So here's the information for getting your CME. So there'll be an evaluation to complete online. I do understand that a couple of hospitals had a really high census today and a lot of nurses weren't able to make it to this training. So what we'll do is we'll send you a link where we'll post the video. folks can watch the video, complete the online evaluation, and still earn those CNEs. So the evaluation link will remain open for 2 weeks until the 14th of May. And then after that, it will close, and I will go ahead and get you all your certificates by the end of the month. If you have any questions, my email is here to contact me. And then real quick, I'd like Renee to come back on and field any questions or comments that you might all have about the training. Any questions? And some comments. Amazing training. So happy to be here with you all. Thank you for including me. Great information.
So I have a question. Is this, have any of you had this kind of training before? Maybe raise your hand, or I have not. Well, I'm so glad then that I was able to be with you here today, and I hope that you learned something. I think the most important thing is just to ask new moms how they're doing, and do it with no judgment. Just, hey, how's it going for you? You know, it can be really tough. And if you're having a great time, awesome. But if you need help, please let us know. Yeah. And I know it can be kind of scary to talk about. When I first started this, I was tripping over my words, but the more you practice saying it, the easier it becomes.
Absolutely. All right. Well, thank you so much, Adrienne and Renee, for joining us today, and for all of your wisdom and your resources and your expertise. Like I said, we'll make this available to you all, and you can either barcode scan the barcode that's here on your screen, or click on the link that's there and get your CNEs. And thank you so much for joining us today. We really appreciate it. And thanks for all you do for moms and babies. Have a great day.
Thanks. Have a great weekend.
Thank you, everyone.